Hello, my name is Justin Schwartz. I am a third-year medical student at Creighton University. Today, I will be presenting a case titled, The Development of Extended-Spectrum Beta-Lactamase-Producing, Gram-Negative, Septic Arthritis, after recent chemotherapy initiation. This project was done in conjunction with the listed medical students, as well as the faculty mentors below. Septic arthritis is an invasion of the joint space by microorganisms. Most cases are due to infectious etiology, with the most common offending organisms being gram-positives, notably staph and strep. Septic arthritis from gram-negative bacilli only occur in 14 to 19% of cases and has a significantly higher incidence in IV drug users and immunocompromised individuals. The incidence of septic arthritis resulting from a gram-negative bacteria that produces extended-spectrum beta-lactamase is an even rarer occurrence. This comprises only 2% of cases. Recognizing the signs and symptoms of septic arthritis allows for timely intervention with arthrocentesis, as well as quick initiation of antibiotic therapy. Prompt treatment initiation is important to avoid complications such as joint destruction, osteomyelitis, and sepsis. The production of extended-spectrum beta-lactamases by the insulting microorganisms further complicate management strategies. This effectively limits antibiotic therapy to the carbapenems. Let's begin the case. The initial presentation was a 64-year-old female who presented to the emergency department for hypoglycemia, 2 days of worsening abdominal pain, both left hip and left knee pain, as well as oliguria. She had a past medical history significant for squamous cell carcinoma of the right lung, for which she was 5 days status post-chemotherapy initiation. Her past medical history was also significant for type 2 diabetes, as well as chronic kidney disease. Her vitals on admission showed an afebrile individual with an oxygen saturation of 82%. On physical exam, the patient was noted to have generalized distress, increased respiratory effort that was associated with Kussmaul breathing, as well as diaphoresis. The initial labs obtained showed quite a significant metabolic derangement, which was concerning for diabetic ketoacidosis. A CT abdomen was performed, which demonstrated bilateral nephrolithiasis, and urine cultures were obtained that were positive for extended-spectrum beta-lactamase-producing E. coli. This is interesting because initial blood cultures were negative for any microorganisms. This patient was immediately started on the DKA protocol. They were also started on meropenem for the positive extended-spectrum beta-lactamase-producing E. coli that was found on urinalysis. However, 2 weeks after admission, the patient then presented again with increased left knee pain that was associated with a decreased range of motion and a decreased ability to ambulate. At this time, a 3-view X-ray of the left knee was obtained and demonstrated soft tissue swelling and evidence of an effusion. Joint arthrocentesis of this left knee was subsequently performed, and cultures came back positive for extended-spectrum beta-lactamase-producing E. coli, and susceptibility testing demonstrated resistance to all penicillins, cephalosporins, and aztreonam. The patient's left knee was subsequently drained and washed out by our colleagues in orthopedic surgery. They were discharged on ertapenem, and they continued to show improvement of their symptoms associated with their septic arthritis. This case illustrates the importance in maintaining a high degree of clinical suspicion for septic arthritis caused by resistant gram-negative bacteria in patients who are immunocompromised. It is important for us to recognize that the recent onset of chemotherapy may have played a role in this patient's immune status. This makes it important to further discuss how long after chemotherapy initiation does one become more at risk for the development of resistant gram-negative organisms causing septic arthritis. Thank you all very much for your time.